Good morning, everyone. My name is Graziano Onder, and I am the moderator of this session. We have now reached the number of 42 participants. It's 11:32, so I believe we can start this session. I kindly ask if I can have my slides on the screen so we can start the session. So as I said, I'm the moderator of this session. My name is Graziano Onder, and I'm from the Italian National Institute of Health. As you know, this session will be focused on the results of the CHRODIS Plus project, a project that is mainly focused on non-communicable diseases. The title of the session is Closing the Evidence Practice Gap on Non-Communicable Diseases, Translation, Transfer, and Sustainability for Comprehensive Responses Across Europe. Next slides, please. So I just want to briefly introduce you to the topic and to the CHRODIS Plus Joint Action and describe how the session is organized. And then I will leave the floor to the four speakers of today's symposium. What is the CHRODIS Plus project? CHRODIS Plus is a joint action funded by the health program of the European Union. The CHRODIS Plus joint action involves 42 partners in 21 European countries, and its main focus is on non-communicable diseases and implementation of good practices for non-communicable diseases. So sharing good practices and put them in practice, and put them in place and implement them in real world. Next slide, please. The main activities of the joint action CHRODIS are the two you can see in the boxes here. First of all, policy dialogues. 17 policy dialogues, 15 at the national level and 2 at the European level, aim to increase decision makers' awareness and acceptance of improved actions to combat chronic diseases. And the second mission of the joint action is, as I said at the beginning, implementation. 21 implementation projects with a specific focus on 4 different areas. Next, please. That are health, former one, please. Okay. That are health promotion and disease prevention, multimorbidity care, quality criteria and recommendation tools, and employment and chronic diseases. So we had in the CHRODIS Plus joint action 21 implementation and pilot actions focused on these different areas. Next, please. So today's speakers will focus their presentations on these topics, and they will present on successful scale-up of multimorbidity care model. This presentation will be done by Aurelius Veriga, the Minister of Health of Republic of Lithuania. Alison Massen from EuroHealthNet will present on policy dialogues and the power of policy dialogues, on practical examples of a key tool for progresses in societies. Francisco Ruiz Dominguez from the Andalusian Regional Ministry of Health and Families will present on elements and practice transfer, a transfer of a relevant practice from Lombardy region in Italy to Andalusia, a practice working in the field of health promotion and prevention. And finally, Valentina Stramiello from European Patients Forum will bring in the voice of patients and will underline the EU citizens' role in group practice implementation. So these will be the 4 speakers and topics for today's symposium. Next slide, please. How is the symposium organized? We will have the 4 lightning talks. Each talk will last for 5 minutes. And so overall 20 minutes for the 4 talks. After the talks, participants will be divided in 3 breakout groups. And the speakers, the three speakers, unfortunately, Dr. Veriga will not be able to join us for this part of the session. The three speakers will rotate across the three small groups, the three breakout groups. So participants will have the opportunity to make questions to speakers in a very interactive way and in small groups. After that, we will have the panel discussion that will last for about 25 minutes, where we will bring the main questions that were raised during the interactive sessions to the main panel and to the general discussion. And finally, we will have final remarks and wrap up of the overall session. Just before starting, a request for all participants to mute their microphone while the presenters are, while the speakers are presenting their talks. Hope you can open your microphone in the breakout groups where you'll be able to pose questions, to make questions to the speakers. So having said that, I will open the floor to the first speaker, and it's really a pleasure for me to introduce Dr. Aurelius Veriga, that is Minister of Health of the Republic of Lithuania. Dr. Veriga is a psychiatrist with more than 10 years of professional experience. He worked from 2011 to 2016 as head of the Health Research Institute under the Faculty of Public Health of the Lithuanian University of Health Sciences. And since December 2016, as I said, he is Minister of Health of the Republic of Lithuania. So his talk will focus on successful scale-up of the multimorbidity care model, from pilot to implementation of the integrated multimorbidity care model at the national level in Lithuania. So Dr. Veriga, please, the floor is yours.
Thank you very much. Hello, everyone. And it is my pleasure to be with you today. And I'll try to do my best to share in short. I have to say, in my opinion, the success story of moving from the research to pilot and then to national implementation of integrated multimorbidity care model in Lithuania. Next slide, please. So I would like to start from description of the problem that probably every country has the same challenge, and we are facing the societal changes in our countries, and it's mainly associated with an aging society. At the same time, we're getting more and more people with the chronic illnesses, with the chronic conditions, and it looks like it starts very early. Even with the age 28, we already have people with several chronic conditions, and at least in Lithuania, more than 60% of people aged 65 plus has at least 2 chronic conditions. And of course, it creates several problems. Those people are twice more likely to go for an outpatient visits. They have almost 10 times more frequent home visits, and they are more likely for the hospital readmissions in 30 days. And of course, it is associated with economic losses and challenges for the health systems. And this project, the CHRODIS, and all the intention to change the system and introduce the new models dealing with the multimorbidity associated patients are very much associated with the Lithuanian government goals. And Lithuanian government is performing 6 structural reforms, and one is associated with the healthcare. And in this healthcare part, one of the strategic goal is primary healthcare development projects, mainly aiming to improve the quality and availability of healthcare sectors, reduce the waiting time for the patients, and also reduce the number of cases of avoidable hospitalizations. And implementation of this integrated multimorbidity care model is one way to reach the strategic goals. And we are lucky that we have already available knowledge that was produced in previous project CHRODIS. And we have a theoretical background that could be piloted and implemented in the countries, and who would, of course, benefit from that. And at the first line, there are patients who would be enabled to actively take part in their treatment and supervision. And then, of course, empowerment of nursing care through teaching and increased responsibilities, and also empowerment and strengthening the primary care by providing the new tools for the healthcare workers. Next slide, please. And maybe we will skip this one just to keep on time. So let's move to the steps for action and how Lithuania did that. So first, as I've mentioned during the first joint action CHRODIS, the integrated multimorbidity model was developed. And under the Krodis Plus, from 2017 to 2020, 2 pilot projects were implemented by 2 main country hospitals based on Krodis Plus implementation strategy. And during the final year of the project, the collaboration process with the OECD expert group was initiated in order to evaluate cost effectiveness. And Ministry of Health seeks to ensure the quality and sustainability of primary healthcare services. And it is extremely important to have a science-based methodology and recommendations for that purpose. And model will be tested for 2 years from 2020 to 2022 with clearly defined KPIs. And after this period, Ministry of Health will evaluate the outcomes, compare them by benefits, and implement the most effective and exclusively adopted for Lithuania multi-morbidity healthcare service models at national level. Next slide, please. So how we are going to scale it up? So first of all, 15 different IMCM will be tested in Lithuania, and models testing will be implemented in 23 municipalities. It's a bit more than 1/3 of overall number of municipalities. We have 60 of them. 46 primary healthcare institutions will take part with more than 700 team members, and more than 7,000 patients will be involved into that process. And next slide, please. And what are expected benefits? They will target the patients, medical staff, and healthcare system. And we expect with that to increase the life expectancy, better the clinical outcomes, service availability, remote health services availability, at the same time decrease the administrative burden, increase the professional competence, teamwork, working conditions, and for the healthcare system, decrease the number of hospitalizations, especially avoidable hospitalizations, outpatient visits, home visits, and hospital readmissions. So that's in short. Thank you very much for listening.
Thank you very much, Dr. Veriga, for your interesting presentation. So as I said at the beginning, participants will not make questions now, but will do questions to the speakers in the breakout groups after the lightning talks have been completed. So we will move now to the second speaker, Alison Massen, Senior Coordinator of EuroHealthNet, will present on power of national policy dialogues, practical example of a key tool for progress in society. As I said, Alison is Senior Coordinator of EuroHealthNet. EuroHealthNet led the planning and execution of 14 national and 2 EU-level Krodis Plus policy dialogues. So Alison, thank you for participating in this session. The floor is yours.
Yes, good morning, Graziano. Good morning, everyone. Thank you so much for joining us for this session today. It's really a pleasure and an honor to be able to present on behalf of CHRODIS Plus, because over the course of the last 3 years, the Joint Action has done a lot of very interesting work. So building on what you've heard from our first two speakers, I'd like to talk to you about the national policy dialogues and indeed how these dialogues could represent a potential tool for progress against NCDs in our societies. Next slide, please. So here you can see a map demonstrating where the 14 national policy dialogues were held. And in fact, as mentioned in the introduction, there were initially 15 planned, but one of them in the end was not able to go through. We also had 2 EU-level policy dialogues on the topics of financing of health promotion, in which case we looked specifically at EU funding, and employment and chronic disease. The topics for the national policy dialogues varied widely, from major risk factors for NCDs such as tobacco control, a healthy diet, active lifestyle, to more narrow but still important topics like mental health literacy during divorce or water consumption in school. And I think that the variety of topics is a really powerful illustration of the variety of risk factors for NCDs and the variety of policy levers that we can manipulate in order to try to reduce chronic disease burdens in our respective countries. Next slide, please. So this is a very simplified illustration of the CHRODIS Plus policy dialogue process. And all of the documents that I'm going to talk about here are available on the CHRODIS Plus website as templates. So we would encourage you to visit the website, which hopefully we'll link in the chat feature here, and to take a look at the tools and get in touch with us if you'd like to use them or if you have any questions. And so I would say in this process, in fact, the most important step was the preparation. And one of the key parts of the preparation was developing a questionnaire, developing and responding to a questionnaire between the national organizers in each country and the CHRODIS Plus organizers. And as a part of this questionnaire process, we narrowed down on what topic to select in each country, as well as who were the relevant stakeholders to participate in a policy dialogue on that topic. So there was some context analysis and stakeholder mapping conducted as a part of the questionnaire. In addition, the questionnaire also asked national organizers to think about EU added value, both to the dialogue, what could they build on that had been done in other EU member states or at the EU level, and what additional added value would that national dialogue bring to larger EU processes. So once the topic had been selected and participants identified and invited, the dialogue was held. It tended to be a half-day closed-door session with between 10 to 15 participants in each session who actively participated. Each dialogue had a moderator who was there to keep the participants on track and to shepherd the conversation towards some final conclusions. And there was also a reporter who was, or rapporteur, who was responsible for taking the minutes of the meeting and compiling a final report. And these final reports, I should mention, were written using Chatham House rules. So we were able to present what was said, but not who said it, as we felt that that confidentiality allowed the participants to be a little bit more open and frank about some of the barriers that might not be commonly spoken barriers in their countries. The final stage in the dialogue itself was the development of an action plan, which, as the name suggests, was a list of action points that the participants agreed on based on their consensus and conclusions coming from the dialogue. For each of those action points, an associated actor was assigned to be responsible for taking it forward, and an indicative timeline was also laid out. And in some cases, some metrics for monitoring and accountability were also identified at that stage. Then in the follow-up, in this case, we had a participant feedback survey that was sent to all of the dialogue participants in each country to gauge their feedback on how the dialogue went, continuing barriers, existing opportunities, and so on. And then the actual implementation of the action plan that I mentioned. Next slide, please. So in this final, in this initial lightning round, I just wanted to quickly take us to what we thought were some success areas, success factors, and some areas for future improvement. And hopefully in the breakout session, we'll have more opportunities to speak in depth about specific policy dialogues or the process. So to this question, how can policy dialogues support closing the evidence practice gap on NCDs? Well, first of all, we've thought that they were very effective at bringing evidence into policy and enhancing EU added value. As I mentioned, these questionnaires that we developed asked the national organizers to look at existing evidence and to look at existing practices and policies from across the EU to think about how that could support their policy dialogue. We also thought that they were a valuable framework for encouraging a health in all policies approach and addressing complexity. So many of the stakeholders invited to participate in the policy dialogues came from outside of the health sector, as many of the risk factors for NCDs we know also come from outside of the health sector: education, environment, finance, private sector. It was quite varied. The policy dialogue process was also a good structure for improving transparency and standardization of policymaking. So the fact that this was successfully applied in 14 different national contexts, we thought that that was a very positive demonstration. And finally, related to the action plans I mentioned, they were a good process for integrating policy dialogue conclusions into future action. And then finally, areas to improve, which I think are endemic to all projects with a short lifespan. We feel that it would be important to consider how you can provide for adequate human, financial, and technical resources to carry out the action plans over the long term. And then monitoring and evaluating outcomes of the dialogue, again, over the long term. And finally, ensuring sustained political commitment for the long term. So with that, I'll close for now, but I hope we have the opportunity to speak more in the breakout session. Thanks very much.
Thank you, Alison. And so it's time to move to the third speaker, Dr. Francisco Ruiz. He will present on challenges encountered on health promotion and disease prevention, important elements of the Lombardy Workplace Health Promotion Network, good practice transfer to Andalusia. Brief presentation. Dr. Francisco Ruiz is an expert in health promotion, and he is an health promotion advisor at the Regional Ministry of Health in Andalusia, which is the second largest and most populated region in Spain. So Dr. Ruiz, the floor is yours. Thank you.
Thank you very much, everyone. Welcome. It's a pleasure and of course an honor to join this CHRODIS session in European Health Forum guest time. Thank you for the invitation. We in Andalusia participated in Joint Action CHRODIS and Joint Action CHRODIS Plus. So that's been about 3 years in a row working on preventing chronic risk factors of chronic diseases, trying to foster the well-being, trying to promote the health of citizens in Europe and in the whole world. Our main aim is health promotion, and we are going to illustrate or try to illustrate in this presentation the task we have been involved to implement or transfer a good practice that was originally from Lombardy. So let me just join the brief presentation I have prepared with the help of my co-workers and also the help of some people in EuroHealthNet. I am using the base of a video that we are preparing, the video script we are preparing to present in the upcoming CHRODIS conference. So please, let's start, and we'll continue. Any questions you may ask during the breakout groups. So I refer to the chronic diseases, and I wanted to refer that they are the main cause of disability and death worldwide. So factors like smoking, unhealthy diets, sedentary lifestyles, they are all modifiable. So that means that effective and inexpensive actions can be taken to promote health and prevent the onset of these chronic diseases. That's why we want to emphasize many settings where health promotion actions can be taken, such as workplaces. These are suitable environments to support health and encourage health habits. So as I referred before, the European Joint Action CHRODIS already selected a good practice. That practice was owned by Lombardy region, and it dealt about workplace health promotion. They found that the intervention positively reduced a number of risk factors of chronic diseases. So in 2019, next slide, please, we choose to implement a pilot study of this workplace health promotion intervention in 2 organizations in Granada, in Andalusia, Spain. And we followed the systematic strategy defined by Krodis Plus. The intervention consisted of different steps that I list there, with strong emphasis on situation analysis and scientific methodology to also follow up indicators and carry out evaluation, apart from of course, the core health promotion actions. We also wanted to recognize or implement a recognition system for the health promoting organizations. Next slide, please. So at the initial stage, introductory health promoting sections were held in each organization for all employees, and then practical workshops and health promotion actions were offered to the workforce free of charge and on a voluntary basis. After the first 9 months of intervention, we already have results and data that seems very promising. There has been found an increase in physical activity among the participants, as well as an increase in the intake of fruits and vegetables, and a consequent reduction in the consumption of sugary products. Next slide, please. Now, Andalusia is carrying out piloting to reach the original Lombardy 3-year intervention model. So both regions, Lombardy and Andalusia, are going to continue their collaboration on this transfer, and this will make it possible to enjoy and to offer an Andalusian workplace health promotion program that has been improved and that is expected to benefit to more than 7,000 employees in Andalusia at the first step. So that's all from my side for now, and you are very welcome to join later with any questions. Thank you very much.
Thank you very much, Francisco, for being on time. And so our last speaker is Valentina Stramiello from European Patients Forum. She will present on how to reach thousands, EU citizens' role in good practice implementation. Valentina is working for EPF, and she's a senior program manager and oversees the EPF project portfolio, including Joint Action CHRODIS and CHRODIS Plus. So Valentina, thank you very much for joining us. The floor is yours.
Thank you, Graziano, and thank you to the European Health Forum Gastein for inviting me to represent the patient and citizens' perspective in CHRODIS Plus. So I will share some information about how EPF and in general patients and citizens were involved in this project. But as just Francisco did, I cannot mention the success stories of CHRODIS Plus without mentioning CHRODIS. I would say that in terms of patient involvement and citizens involvement, the Joint Action CHRODIS was really fundamental to make it to make then CHRODIS Plus success in implementing the pilots. Next slide, please. So what was really important is that as EPF, we were involved since the design phase of the guidance, the recommendations and the models that have then informed the implementing sites in CHRODIS Plus. In particular, we have been involved in the development of the Joint Action CHRODIS recommendations and quality criteria, and the multimorbidity care model. Those two documents were fundamental to allow the right design and implementation of the pilots. What I personally experienced in the Joint Action CHRODIS is that working together with other stakeholders, with other partners, we were able to change mindsets and also their culture in some cases. So I would say getting patients and patient organizations involved since the early stage had a major impact within the project first, and then potentially also in the pilots. Next slide, please. So after we delivered those models and recommendations, so we decided in Joint Action CHRODIS Plus to implement the recommendations. And so more than 21 pilots were designed, and those design was already developed, including EPF and other patient organizations. To make sure that even the design of the pilots would integrate and address patients' needs. Then, once the design of the pilots was delivered, we have experienced, again, a change in mindset and culture among the piloters. And what we are perceiving right now at the end of the pilots is that even patients' views are better integrated and practice bring better outcomes. We are now coming to the end of the Joint Action CHRODIS Plus, and we have already witnessed this change in the mindset. Piloters have come back to us sharing that actually for them, these pilots were a learning opportunity. They could really see how integrating the patient view since the very beginning of the process has brought better outcomes of the practices. So I would say the major recommendations from our perspective is whenever you want to launch a program, you need to involve patients since the early stage of the design process. Involving patients or citizens in the validation phase is not enough. The risk is that, of course, programs that don't meet patients' needs will be delivered. So it's a question of efficiency. It's a question of addressing patients' needs. And of course, overall, it's a question of addressing the public health system needs. Then next slide, please. So this is just to conclude. Our leitmotif in Work Package 7, in Work Package 6, in CHRODIS Plus was always this need to move from doing things to patients to doing things with patients. We have seen this cultural change, and we hope that this improvement will stay in the future after the end of the Joint Action CHRODIS Plus. Thank you.
Thank you very much, Valentina. So what's going on now? All participants to this session will be divided in 3 breakout groups. The 3 speakers, Francisco, Valentina, and Alison, will rotate in these groups 10 minutes each. So you will have the opportunity to make questions to the speakers in small groups. So I asked the coordinating team to share, to divide participants in groups in order that we can start the breakout session. After the breakout session, we will be back to a full session where all questions that were raised during the breakout session will be posed to the speakers, and we will have a wider discussion. So please, coordinating team, if you can divide participants in breakout groups, we can start the discussion. So welcome back, everybody, to the full session. We will now have a panel discussion, meaning that the 3 speakers can answer to the questions that were raised during the breakout groups, or to new questions that the participants may have. So I have to say we had a very good discussion, at least with Francisco related to health promotion and prevention and to what was done in Andalusia. And I feel it might be good if we can bring the questions to that were made, the most relevant questions that were made during the breakout session, to the speakers now in this full session. So I kindly ask Leimis and Lina also to summarize the most relevant questions that Alison and Valentina have received during the breakout session. Also, Dr. Veriga will not be with us now, but if you have any urgent question about what happened or what was done in Lithuania during the Krodis project, Rokas Navikas can answer to some of these questions. Clearly, he cannot speak as for mandate of the Ministry of Health, but if there's any urgent question related to the experience, the Lithuanian experience, and the scale up, Rokas will try to answer. I would like to start saying that during the breakout session, Francisco received several relevant questions. First of all, related to the scale up and sustainability of what was done. And I believe this is a key point of the overall CHRODIS Joint Action. The project is coming to an end in 1 month, but really a lot has been done and many pilot implementations have been performed in different countries. So it's now time for different regions and countries to think about scale up, as was done in Lithuania and as Dr. Veriga showed up. So my first question that I will make to Francisco, and he will probably repeat what he has already discussed in the breakout session, is about sustainability and scale up of what was done. And please, I also see that there are many Krodis partners among participants to the symposium. Feel free to jump in the discussion and also show what kind of larger scale implementation and scale up can be done in your country. So please, Francisco, repeat for the full group what are your thoughts about sustainability and scale up of what you have done so far. And also, Rokas, after that, if you want just to briefly underline once more what has been done in Lithuania and what is the plan in Lithuania. It was already showed very well by Dr. Veriga, but I think it's worth to underline that again and bring your experience in. So Francisco and Rokas, please.
Well, I share in one of the 3 breakout sessions that we already received requests from OECD to know more about our experience. We are meeting with them next Friday. We also received last year thought out questionnaire, and they wanted to know more from the Irish health executive department. And also we received requests from the Netherlands. We were supposed to be meeting in April, but then there in the Netherlands, I mean, and then the COVID situation discontinued our plan. But I'm very positive that we will be also sharing our experience with their colleagues, there in the Netherlands. So a whole number of possibilities to cooperate, and situations are being made possible thanks to this program. The Joint Action CHRODIS has made it possible for us to gain the experience, to put it into practice, to transfer it from Lombardy. We are very satisfied with the collaboration with the region of Lombardy. I think they propose us to keep on to be continuing this collaboration for the upcoming years. I'm very positive that our presence in pilot experience will keep on attracting interest in the coming years. We are looking forward to the general final CHRODIS conference, and as well as the Spain-wide, nationwide conference taking place in November. I'm sure that this will make people know about this experience and will elicit the possibility for others to also try and consider this workplace health promotion initiative.
Thank you, Francisco. Rokas?
Hello, everyone. So a quick recap on what's been done in Lithuania. So that will, in a way, repeat what the minister already presented. But over the years, we had two pilots, which happened in two major university hospitals in Lithuania, covering 2/3 of the country. But the number of patients involved was limited to 500 patients over the two hospitals, to assess if the model, the multimorbidity model, is feasible within the country. After a year of piloting and close collaboration with the ministry, a ministry launched a national scale-up project with over 10 million euros directed towards further assessment of the multimorbidity care model nationally. Thinking that over the 2-year period, even more adjusted multimorbidity care model would be developed, and during the time frame, the benefits, potential benefits and outcomes for patients, institutions, and the system will become visible. If that was the case, then obviously the plan was to carry on and ensure sustainability of those tools through different means, what is feasible for the health ministry. And in the meantime, I would like to share that we are also collaborating with OECD, who will be assessing the potential economical benefits from the multimorbidity care model. So that's a short recap, but I'm happy to take any questions if there are.
Thank you, Rokas. So I see there were also questions for Alison and for Valentina. One of the questions for Alison that I believe was raised during the breakout session relates to what actionable insight could you capture from policy dialogues? This is a question that Lina has forwarded to me, but I kindly ask you to answer this question in this panel session, so everybody can participate in the discussion and listen to your answer. So thank you, Alison.
No, thank you, Graziano, and thank you. I don't recall who asked the question, but it is a very good one. Actionable insights. I think for me, a lot of the actionable insights vary depending on the policy dialogue itself. That was the purpose of the action plans following each dialogue. Those action plans were intended to be actionable insights for each country to then respectively move toward achieving the objectives that they had outlined for their policy dialogue. And some of that information is available publicly, but of course, as we said, not everything, as the dialogues were held under Chatham House rules. So if you are interested in any particular policy dialogue that happened in a certain country or in the EU level dialogues, we're happy to direct you to the information. From the overall process, I would really say actionable insights for me came from the process itself. We found that it was surprisingly robust, the model, across a lot of different types of countries and a lot of different types of contexts. Some countries were using the model at the very early stages of thinking about a new topic, how to put the topic on the agenda for the first time. Others were looking at topics that had been on the agenda for quite some time, but how to take them to the next level. So we think that the methodology in itself, the questionnaire that was used, for example, the guidance to the national organizers, that was quite actionable. Another country, another EU project could take that same format and then apply it in different settings. And I think it's also important, and this came up in the first breakout, to remember that the policy dialogue shouldn't be just a single item happening in a vacuum. It really should be part of a longer policy process, and you could have multiple dialogues over the course of moving a policy topic along the agenda, or moving a specific dossier toward implementation. So to me, that's all very actionable. What do we do with how do we do this? We know we have these certain objectives, and how can we use a policy dialogue to support achieving those objectives? Thanks.
Thank you very much, Alison. I also have a question that is both for Valentina and Alison together, because one of the questions that was raised during the during the breakout session relates to the involvement of patients in policy dialogues and policy making. So the question for Alison is if patients were part of this process. And the question for Valentina is, how can we make patients more involved in this, in policy making, and aware of, or more participating in changing policies? So the question is for both of you. Who starts? Alison, probably. Yeah, thank you.
Sure, I'm happy to start. So in some cases, yes, there were patients involved, but generally not as much as I think the participants would have liked, because one of the there was intersectoral collaboration in the dialogues, but it tended to be quite interministerial. You would have a lot of different representatives from different ministries, and in certain cases you had key civil society organizations represented. But given that these initial dialogues were 10 to 15 participants, it was, the space fills up quite quickly. And one of the barriers that was identified in different dialogues in the participant feedback surveys was not having enough of the end users who would be affected by the policy itself represented in the dialogues. So for instance, in the case of Ireland, where they were looking at tobacco control, they indicated that it would have been very nice in particular to reach mental health service users who were also using tobacco. That was a particular target for their policy dialogue. And so in follow-up activities identified in the initial policy dialogue, they then agreed that they would initiate dialogues with stakeholders who hadn't been present in that first part of the process. So yeah, but it depends a lot on the country and again, the strategic objectives of the dialogues.
Thank you, Alison. Valentina, so what should we do of the patient more in depth in policies, dialogues, and in policy making?
So I would say the first point is to allow patient involvement. Patients need to have the opportunity to get involved. This is really the gatekeeper to patient involvement, I would say. And as I had already mentioned, as EPF, we have tried to change the mindset within the joint action, but also among partners, to really see what is the potential of patient involvement in all the activities that we were performing. What is also needed, I would say, in some cases, is capacity building of patient organizations. In some cases, patients might need additional educational tools to be able to then contribute. Often patient involvement goes hand in hand with patient education. So this has also to be taken into account, because not necessarily patients have the skill set to be able to really contribute. And last but not least, of course, human and financial resources in patient organizations sometimes also can make a difference, because patient organizations not necessarily have all of them. And this may also be a barrier to involvement in policy making. And this also would apply to the policy dialogues in this case.
So Valentina, I have another question that is in line with what you have just said, and I believe it's something that was raised during the breakout session. So what were the challenges to involve patients in this in the process? I mean, you mentioned that they need specific skills, probably, or they have to improve some skills. And I know there are experiences of European patient academies or organizations that are training patients to improve their health literacy or their skills in this way. So the question is, did you encounter any challenge to involve patients in the process of CHRODIS, and what are the specific skills that probably are needed by patients in order to be more involved in the process of organizing their care and organizing the overall ways the care is provided?
So it really depends. When it comes to the skill set, it really depends on the questions to be addressed. So if we are talking about medicine development programs like EUPATI, maybe the response, because they really provide training on research medicine development, and they are very useful to show how things work when it comes to this field. When it comes, for example, to providing input into the public health systems, then the skill set is maybe not so specific to, you don't really need to have scientific knowledge, but rather bring your experiential knowledge, we would say in this case. All in all, I would say it's having an understanding of the organizational aspects of public health systems. So we don't expect very naive patients to be able to contribute to complex discussions. We are aware that they need to be patients with strong advocacy skills. And this is what we do as EPF. We organize a lot of trainings, and often they are very diverse training programs to be able to address all of these aspects. I hope I have responded to your questions, or if
yes,
there is more
absolutely.
than that.
I also want to underline the chat, a message in the chat by Astri about this question, underlying that it is not so much about patients needing training, but more the attitude towards what kind of expertise patient representatives can bring to the table.
This is also a good point, indeed.
Relevant point, which I believe also you agree.
Yes, sure. No, of course. We always say when it comes to patient engagement or patient involvement, we don't need to train just the patient. We need to train all the parts involved. We need to train also other stakeholders. Sometimes we need to train healthcare professionals and policymakers. So to make a patient involvement effective, you cannot just count on the patient to step up. Sometimes it's for others to be able to understand and to listen to the patient.
So thank you, Valentina. We still have a few minutes. So I'm kindly asking participants if they want to raise a very last question to the speakers. So feel free to jump in and open your microphone and make the question.
All right. Can I ask?
Please, Dovile.
Yeah, I'm Dovile from CoronaNet Research Group, and I previously addressed the question mainly to Lithuanian government representative, but maybe Rokas can comment more on that, but I think it's also relevant to ours. So I wanted to ask what kind of evaluation criteria Lithuanian government is using to measure the benefits and outcomes of this program, and mainly not economic ones, because this one is all clear, but for instance, how are you going to measure professional competence or those softer skills benefits you mentioned?
Rokas, can you answer this question?
I will try. Yes, I cannot speak on behalf of the ministry, obviously, but I could comment from on behalf of our teams when we were doing the implementation. So you are completely right. The outcomes, the long-term outcomes, they need a long time to be seen. So we are not very good at measuring health life years gained, what we would be expecting to see in 10 years or so, or reduced number of hospitalizations, or reduced number of rehospitalizations. That is too short of a time. However, there are other means to measure the quality through patient's perspective, so patient-reported outcomes. And that was measured when we were piloting. Also, medical personnel reported outcomes, so how they feel, how do they feel in that role, do they have any support, do they evaluate it as well, so on and so forth. So we are basically limited to the short-term outcomes, which has its downsides. When we're talking about the national scale-up, so the project has just finished identifying who will be the partners, and it's just about to begin. So I believe the measuring thing will be done as we speak. So this is probably a little bit too early to start debating about that. But thank you very much for a really good question, though.
So thank you very much, Rokas. Dovil, you have other questions or other comments on this? Okay, good. So we are running out of time. So I just want to close this session with a specific thought related to the Krodis Plus project. I believe this project really has done a lot. In terms of implementation and changing practices throughout Europe. And it was very successful, I feel, in improving the care to many patients in Europe and in promoting and health promotion and prevention. I feel that we made many regions, even if Krodis Plus were not brought on by the European, by the health program, well, it made possible several changes at a regional level that will scale up, and we have the great examples of Andalusia and Lithuania here that scale up what was started by Krodis Plus project. In addition, policy dialogues were relevant. They were a step in order to change policies. So we did provide evidence on one side, and we pushed towards changing policies based on the evidence that we have produced in the Krodis Plus project. So I believe this made the project really complete, because it really assessed two important parts of the care of persons with chronic diseases and prevention of chronic diseases. So having said that, I really believe that the Krodis Plus project that is going to end in 1 month from now really opened the way for further scale up and for further implementation of good models. And I strongly believe that some changes were made possible in European countries due to the Krodis project. Having said that, I really thank all participants, the speakers, Valentina, Alison, Francisco, and Aurelio Studies not here now, and the organizing team of the Gestern Forum for having this opportunity. And I will hope there will be opportunities to talk about non-communicable diseases again, probably in Gestern next year or even earlier if possible. So thank you very much, and I hope I will have the opportunity to see you again and talk about non-communicable diseases. Take care, and thank you again.